I guess I'll start by just explaining that one title because it always catches people's attention where it says Education Coordination. So the idea that the Vice Dean of Education had is that needed somebody in today's era to think about, plan, manage, handle, address the areas that cross silos. So interprofessional education, the library, IT used for education. And so that's what I do. I deal with things that cross multiple systems within the health system for education as opposed to just dealing with UME or just dealing with some component thereof. So that's where the education coordination came from. So thank you very much for inviting me. We're going to move along because I've seen the time cards, so I don't want to see one of those at the end of this. I don't really have anything relevant financial to disclose today. This is what we're going to try to cover. I'm going to cover what I call the foundations in adult and physician education. Speaking to an education office, you probably are going to know much, if not all of it. And I'll be honest, we could probably stop on any one slide and spend the entire hour arguing as to whether it's completely factual and what the counter arguments to that are. So bear with me, I hope you will. And we'll ask the question, are physicians the same as other adults? And I'll give some thoughts there. We'll cover the literature that exists on does lifelong learning really connect to outcomes. So the question here is going to be, really, is lifelong learning based in adult education principles? Not only does it connect to outcomes, but what's it based in presently? Then I will wrap up at the end before I cover a few issues of where I think this field, CME and education and outcomes is going. I'll spend about 3 or 4 slides talking about are physicians like fine wine? Do we get better with age? So, which has more importance to me every year. So I just thought a little joke to get us going here. I probably remember 20% of the stuff I learned in school and forgot the other 90%. We hear this all the time, right? So here's what we're going to cover in the foundations. Again, I hope most of the people in the room can almost predict what I'm going to say just seeing the names of some of the stuff that I'm going to cover. And the flow here is to try to go from topic to topic very briefly and hit the high points here. So I want to start with Dale, what's called Dale's Cone of Learning, and admit from the beginning, you have invited me today so that you might remember 20% of what I say, because you've asked me to come and do something relatively didactic. So one of the first questions we have to ask ourselves are, do didactic education work or not? And Dave Davis's work is commonly quoted amongst others as saying it doesn't. That's not really what Dave says, and it's not really what his work showed. It showed it's less effective than other methodologies, not that it's totally ineffective. In fact, one of the most effective mechanisms for this sort of presentation really is awareness, right? So what do I want you to be aware of? You're unlikely to change based upon something you hear today. What do I want you to leave and be aware of? I want you to leave and be aware of that CME is connected to patient outcomes in some domains, and I want you to be aware that CME has not been designed based upon adult principles up until today and is becoming so. So that's what I want you to walk away with. So we're going to do passive learning. We're not here doing a workshop or hands-on, but it would be better if we could spend the time actually thinking about how to role play and think about how we might actually change what we do and how we educate in order to get physicians to perform better in terms of patient care and patient outcome. So the next question becomes, in my mind, do adults and children learn via the same principles? So what are this foundation of education that we all think about in terms of pedagogical education? And pedagogy, to lead the child, is true for adults and for children, but it really comes from a background of teaching kids, and its foundation is the art and science of teaching, so it's true in adult space as well. But there is a field, not that every educator believes that it's distinct and it exists, and again, this is one of those topics we could probably spend a day, if not a week, arguing, but a field of andragogical education. And I happen to believe that this is critical, and I will go into a little more detail to try to show you why I think it is in the field of where we're trying to move physicians to do something. Now again, I'm mostly focusing at CME today. I would suggest the UME end is a transition point, and some of the points today I think do apply and some may not. GME is much closer to the CME world in my personal opinion. But let's cover what I'm referring to here in case you're not aware. So although Malcolm Knowles didn't coin the term, he's credited with being the father and the big proponent of this sort of field. And let's think about it. It has these 7 sort of basic criteria. So adults are going to learn better, they're going to learn more, they're going to incorporate and be able to use it if they understand the reason for learning something, not just showing up in the classroom to learn it. It needs to be experiential. So we commonly see board review courses and stuff where people say, well, I'm teaching chapter 13 because it's chapter 13. The chance you're going to convey something to the audience that's going to move them to do something different is much less. Not zero, but much less because it's not experiential based. They may not understand, is it relevant to their practice at that point or to whatever they're going to do. Adults do better when they take responsibility for what they're going to learn. So maybe we could have started today and you could have filled out a form, are you here to change? Are you making a commitment to change something you're going to do in medical education? And were you committed before you came in the room? Will you be committed at the end? Will you state publicly what that commitment is and what you will change? These become very important. We all think we learn better when it's patient-centered or case-based, problem-based. And then one I'm going to cover the least and not refer to as much because there's very little data about, but is this issue of internal versus external motivators. But I will come back and mention that when I get to one of the future slides. So I look at this as peer and have rearranged them so that I can easily remember them and think about them when I'm trying to meet with people who want to construct CME, and I ask, have you done this? Are you doing it? Are you thinking about, are your lectures just lectures? Are you up there to talk about cardiovascular disease and pregnancy? And are you going to start that lecture with a case or a problem to make it real for the audience and something they can connect to and learn? Or are you there to say, hi, today I do research in and I'm here to tell you about, and there's no connection. It's not really problem-based, or you're hoping their wiring makes those connections for them. The next foundational piece I'll not spend a ton of time on either is this issue of competency. And I just want you to reflect, some people think it's dichotomous. You're either competent or you're not. I don't. I fall into the Dreyfus camp that thinks that there's some ladder, some progression from being less competent to being more competent. Some might argue there's a master level above expert. I think we all recognize that this was created really for skill development, but that most people think it also applies into the cognitive domain. Now this is the same basic ladder redone in a more complex way. And I know you're not going to be able to read every cell. It's not here for you to read every cell. I just wanted to make the point that if there were younger people in the audience, that you do transition from sort of knowing what, knowing that, into knowing how. Let me give a clinical example I see all the time. And 25 years of teaching in the ICU, and I ask almost every week that I'm in the ICU the following question on rounds when they present a patient whose blood urea nitrogen is elevated in proportion to the creatinine. And I'll say, what are the most common causes of that? And they can't fight over top of each other fast enough to say dehydration. And then I say, why does dehydration make your BUN elevated out of proportion to your creatinine? And in 25 years at Hopkins, under 10 people have had an answer. Majority go, I don't know. It does. It's filtered differently. They don't have a what. They don't know the how and the background. And this is what I really get concerned about in many CME environments. We have limited time. And in the possible world now of time-constrained education, we run the risk that we're teaching them this end and leaving part of this end out. What's most important, though, is not on the slide, and I'm going to put it on the slide, which is the question is, does that arrow exist? I know when I trained, I was told I'm going to become an expert or a master at the end of my residency and fellowship, and then I'm one for life. And so the question is, do we slide back down that curve? Okay? And if we do, then CME makes a lot of sense, right? If we don't, then maybe it doesn't. There's Maslow's stages of learning, and everybody always chuckles a little bit, going from unconsciously incompetent up to unconsciously competent. I would suggest that although this is the stage that people like, because the idea is that you're not really thinking about, you're reacting to and making decisions that are in theory supposed to be appropriate, and it's sort of all occurring behind the scenes, I would suggest that being unconscious is probably not a good idea, and that you're probably here only in certain areas, and you're probably somewhere across the spectrum in other areas. Now, I have to admit, this is not easy for us as physicians. You know, I do ICU. So how do I admit that I don't know it all and I need to attend ongoing education and I need to do things to help myself get better and stay on top of stuff and maintain myself at the top of the Dreyfus curve, and at the same time leave that thought and walk into a room to have an end-of-life discussion with a family? How can I have that discussion if I really, maybe I don't know enough to go in the room and have that discussion? How do I balance that? And so I think we as physicians in particular, I think as more nurses and others are getting into the front lines of clinical care as well, I think we struggle with this idea about, are we a master and what does it really take to stay there? Okay? I spend almost no time on this one. I just really like the idea that we go from learning by rote all the way up into sort of the academic end of things where you start to create new insights. And I like it because I think it transitions to this idea that one of the other foundations is that we use tools. So I'm only going to name two of them. I'll show a couple of slides. 5 tomatoes is a mnemonic, right, for 5280 for the number of feet in a mile. We use mnemonics all the time. An ICU one that it seems like the residents love is right. Rightward shifts of the hemoglobin-oxygen dissociation curve are increases in 2,3-DPG hydrogen ion concentration, acidosis, or temperature. Real simple mnemonics that help us bundle and wrap things up. But we also do the opposite. In fact, we do the opposite more frequently, right? We do chunking. We take complex things and we break them into inordinate chunks, and then we hope we can reassemble those chunks into the overall picture when we need it. So we use tools as a foundation. And tools are typically not taught in CME. It's just data points and facts that are typically. So those are the foundations on the adult principle side. I have a couple more I'm going to hit in just a second, but I wanted to pause and sort of ask, that's nice if it's adults, but are docs different? Do we learn different? And I would say that we claim we are. Whenever we have a conversation about conflict of competency, conflict of interest, how we learn, those lawyers need to do continuing legal education, but we really don't. We can, as I was describing earlier, we can fill out a little punch card at the back of an article with the article open in the journal and then submit it and then say that we actually learned to change our care based upon that. So I think we claim frequently that we're different. I don't think there's any data that suggests that we weren't any different than the rest of the adult population or that we are any different. In fact, I would suggest to you that we are extremely Knowlesian. If we don't cover the complications and the errors, the experience, if it isn't really relevant, if it isn't really problem-based, if we haven't made a commitment to be there to learn something. So if I showed up today because I needed CME credit, the chance, no matter how earth-shattering I would have a message to give you was going to penetrate is very small. So I think we are extremely Knowlesian. Okay? So for all this learning, there has to be something else, and I'm always surprised to learn how many people have not learned about the opposite direction of this, the forgetting side of this. And I think the best way to think about this is the work by Ebbinghaus. And I hope most people here have seen this or similar curves, but in case you haven't, the idea is that you learn something and it decays over time, and then at some interval, if you're exposed again, you relearn to the same point, but notice the slope is different, so the decay is less each time. We don't understand the number of times you need to be exposed or the distance between them. So great foundations for some education research that could be done. How many times do you need to be exposed, and what intervals do you need to be exposed at in order to get the optimal learning? Maybe both as a medical student and then in the CME field as well. Yeah, they look like. So I'm having trouble with my short-term memory. I'm here because of my short-term memory. I'd like to talk to you about my short-term memory, again, just to give us a little bit of a pause. So it would be great if when we pick CME so that we could make a difference in our patients, we could step back and go, you know, I'm pretty good at this, but I'm not so good at that. So I'm going to pick CME that covers that because that's how I could be better at what I do, fulfill my commitment to myself and my patients. So are we good at doing that? Are we good at self-assessing? Not taking an objective assessment, but self-assessing. And the data, at least in the literature, no matter, again, what we think of ourselves, would suggest that physicians have a limited ability to actually identify their own weaknesses, that we're not very good at it, and that the worst accuracy is actually in the highest confident individuals. And so this has been shown in skills where they've taken individuals and said, you know, how good are you at tapping a knee? And then have people go and tap the knee. And the more forceful they said they were great at tapping a knee, actually the worse they were at tapping a knee. And it's been done in other environments. Dave Davis and the group did the systematic review, and this is the essence of what they showed. I think, although you don't see the group sizes here, I know a lot of physicians that are out here. They walk out of every test going, I don't think I did very good. And then it comes back and they got a 98. They did much better than they sort of think they did. But this group is unlikely to be dangerous in terms of patient care because they actually outperform what they claim they do. If anything, they may be a cost issue because if they're doubting their ability, they may be over-testing. Again, that would be a hypothesis that's never been studied. The real concern on the curve, obviously, is the group down here. The group that says they're very good at something and turns out not to be good at all at it.
Does this kind of analysis change at different stages of education?
So I don't know that it's been looked at across UME, GME, and then CME. It's only been looked at, I think, in practicing physicians that I'm aware of. Oops, sorry. So, and then finally, whether you want to use Kirkpatrick's or this is Don Moore's work, you need to have some outcome basis for what you're going to do. So I hope in fairly quick tour fashion, we've gone through what I would consider to be critical adult principles that would, if we design what we do in education, we would get better outcomes of that education, especially as relates to patient care. So now let's cover whether CME as it exists today, or it existed a few years ago at least, is it connected to outcomes? So this is a large body of work that we did. We had a humongous team to do this. We were funded through ARC to take a look at this. This is 95,000. For those who have done systematic reviews, you like this box to be around 100 or so to start peeling out. But when you're getting 95,000 that you're going to have to sit there and peel through, you have an enormous amount of work to do. You can see how they start to pop out in terms of duplicate, dual review and getting excluded numbers, abstract review, then article review, and you end up still with more than you would like to have in this case, 136 studies. I'll point out some problems in a second. Now the next 5 slides cover the core results. They're somewhat busy like this one. They have a little bit of data on them, but I'm going to tell you, when I finish showing you all 5, you're going to say basically all 5 are the same. They're all going to basically show you that, except for one, they're going to basically say that somebody, multiple articles have been able to show you that there is an effectiveness of whatever this is. In this case, knowledge translation, knowledge transition, from knowing less to knowing more. They're going to basically all show you that these are true as trends. Remember, this is a systematic review, so you're identifying trends within the literature. So multiple formats using multiple techniques over multiple exposures. I don't think that should be too surprising now based upon what we know. And they're going to show you that print is the weakest. Passing the article out, telling somebody to go read the journal article, or filling out the little card at the back of the journal at the end of the day is the weakest way. Not zero benefit, just the weakest compared to the others. So this was for knowledge change. This is what we found. These were attitudes, physicians' attitudes about care, about improving care, and et cetera. Same identical for all practical purposes study. As I said, one slide would be a little bit different. We did not find a ton on psychomotor skills. On motor skills, there was a bunch, and it's identical. You see a shift that occurs. But on the psychological end of that, the ability to cognitively think about what you're doing, there was just not a lot that specifically identified itself and focused at that. But behavior, in this case, people in today's world mostly say performance. So would I be thinking about now ordering lipids on the right population of patients? That, so you can see, again, it's essentially word for word the same. You see the percentages start to slide a little bit, but you see the same basic concept. And for patient outcome, again, you see overall the same. We found very insufficient data to even look at or talk about short-term outcome. There was some on long-term, and then again, the same basic trends. So CME is connected with some improvement in some areas. You might say all that matters are the patient outcomes, and it's not connected there. I'm going to cover that in just a second for you. I think there's some connection, but I'll point out why I think it's not in just a second. Part of it is here. So these are doing JDAD criteria for all of those articles, and 5 is the highest quality, 0 is the lowest quality, and what you can see is basically the majority of the studies are poor quality. So the overall grade of the literature in this domain is actually low to very low. We did do, but did not publish, subgroup analysis of those with the highest JDAD criteria, and basically the data was identical. Percentages changed, but the trends were all the same trends. So this wasn't all just bad articles producing this sort of impression. It was in the good articles as well. So since I push so much that I think it's important, I need to point out that for all practical purposes, we couldn't find evidence that anybody in the field of CME was doing anything along adult education. They were just holding activities and then measuring some sort of outcome and writing a paper about it, a pre-post most commonly, et cetera. So I guess at this point you could say, Todd, your hypothesis is wrong. Clearly, if CME is associated with outcomes and isn't based in adult principles, then they're not connected. I would suggest to you that I think that the face validity is in the other direction, that CME has been effective. Doctors are good at learning things, and doctors are good at being committed to wanting to do the right thing. I think that if we really want to get the bang for the buck, the amount of money that's being put into the CME world, whether it's coming out of your pocket or coming out of your institution's pocket, or you're not at work for a week to go to CME, so you're not generating revenue, we need to be able to ensure that we get the most out of that. And so I would suggest if we could correct this problem, I think you would see those slides be even more positive. And again, I'll make another comment in just a second. To be fair to the work, and I could spend the whole hour on this as well, and I won't, there are limitations of all studies. The data was very, very heterogeneous. You could not do a meta-analysis in this field if you tried. There's not a standardized, I'll talk about it later, taxonomy. There's not a standardized conceptual model. There's just so little standardization within the field of CME that it's impossible to try to really come up with something at the higher end of science. We looked at Canadian and American data. We did not look at European data, where the numbers of papers just became way too large as you started to look at other things. I can tell you we looked privately and found the same basic trends, but was not part of the study. And most of the tools that were being used in the studies to measure outcome had no comments about whether the tool was validated. Many were not referenced that they came from something. So the literature just really stunk as of 2007 or so. Now we're comfortable that that data was probably really true, because now what's followed is Cochrane doing a series of reviews, 2009, 2012, 2013, looking at continuing education and or workshops, using audit and feedback directly, or starting to bring gaming theory into the educational domain. And all have seen that there is a movement towards improvement in physician populations. So we think that it is true that the outcomes are connected to CME, and that we just think we could do even better, and that we must do even better, and that the docs deserve it. And I think this is the principal reason, the historic model. What was CME created for? Was it really created in today's world where we're thinking about an outcome of the education? or was it created as an awareness tool? If you became a master or an expert at the end of fellowship, and the thought at the time was you stayed that way your whole career, then all you needed were dude in the front or lady in the front with some black and white slides and the lights turned down low, and if you became aware of new things, you were a master, you were going to be able to be competent at moving forward. So I think this model that we had facilitated, and CME wasn't challenged, just as GME hasn't been, and prior UME wasn't challenged to say, is it connected to outcomes? In fact, I still find on the CME side of the world, when I start talking to activity directors who are very proud of holding the 52nd or 25th annual course in so-and-so, and say, do you understand an education cycle? I get stares back and blank eyes most of the time. So I just like to point out that there is this education cycle, and if it helps you, I'll tell you what I say to them. I say, when you go for your parent-teacher conference at school, if the math teacher or the history teacher said, and you asked, what are y'all teaching my son Johnny? And they said, well, Johnny comes to class, we teach some stuff, and at the end of the year I say, Johnny, you get to go to the next grade, then you would probably go down the hall to the principal and say, what the heck is going on in that class? You would want to know that the teacher and somebody had thought about what do the kids really need to know. They really have hard measurable objectives. They've thought about things like instructional design in a way that many of us in medicine have not done well to date. So you know, when it comes to something about Thanksgiving and they want the kids to learn, they're learning about it in social studies while they're doing Thanksgiving things in art. Multiple different instructional designs across the day or the epoch of time are utilized. We tend not to do that. We tend to just package it in. It's time for your cardiac lecture. Although I think we're getting better at thinking about how to do this. In the CME world, besides, I think, using adult principles, I think the only thing that's in the literature of significance is this idea of commitment to change. That's what CTC is here for. So you can see that it's been studied multiple times by multiple different individuals in multiple different ways, looking at 1-month outcomes and 6-month post-activity outcomes, and has some association with getting better. So this is really, you come, the way it's most formally done, you come at the end of a CME event, you fill out a form saying, this is what I learned when I'm going back to my practice and I'm making a commitment to change. When it's been done really well, they use like NCR paper. You get a copy and you take back to your practice. The course gets a copy of it, and then a month later or 6 months later, they mail you that back and they say, this is what you promised you were going back to change. Did you actually change it? Were you successful? If you were, great. What can you share? Lessons learned. And if you weren't, what barriers did you hit? We can do better education next year by including those pieces of information. And some people thought it needed to be signed. At least Paul Masmanian studied it, and at least in his work it did not. Now, so I think this is important, but this also brings up, so let me just out of curiosity for 30 seconds. So if you filled out a piece of paper and you signed it and submitted it to Dr. Thomas at the end of the day, would that be an internal motivator or an external motivator? So you think it's a personal motivator to you. It has nothing to do with sharing with, so then you don't need to give him the piece of paper. You can walk away with it and... So this is part of the problem, right? We want to get to a point where we have a nice model that we can understand so we can start to figure out what are the variables that are important to put into the environment in order to get the best bang for the buck. And we really haven't done a good job of really thinking them all through. There are other work in the CME world in terms of virtual patients, so standardized patients. This happens to be virtual as opposed to standardized, big difference, but the conceptual model being that, again, when it's practical, when it's more experiential, when it's a little more hands-on, when you're put to the task, when it's relevant to what you do, then people tend to do well with that. I promised you I would get here, and she's not holding up 5 minutes, so I'm still good. Again, debatable stuff, but I'll make the following point, and maybe we'll discuss or argue. So this is work by Beth Williams, her husband, and their group of researchers. And what they found and published is that as we get older, the amount or also measured years into practice, then there are more disciplinary actions at the state board level across all state boards as we get older. Not proof, it's not causation, not trying to claim it is, just trying to say that something's happening that makes it where when you're in practice longer, you're at risk more of disciplinary action. Some association there, okay? Now, Chowdhury published and got a lot of press about this issue. This carried the title by many of the news media that is your doctor really competent, and it is being in practice adequate enough for actually maintaining knowledge and ability. And what he found is that as you got older, again, years out from the end of your residency or fellowship, that your performance and the ability to do diagnostic maneuvers with patients relevant to your practice, treatment decisions, and or measured outcomes worsened over time the farther you were in practice. So if we go back to Beth Williams just to wrap it up in her group, so tied here, older physicians had the lowest knowledge score but the greatest confidence in their knowledge. And you remember the curves I showed you earlier that Dave Davis had shown. So I don't disagree that being in practice teaches you a lot and that you learn a lot, but I don't think it's the be-all and end-all, and I think it's missing the complementary component and that re-equilibration. I also think that it's difficult, and I think the data shows it's difficult for our ability to assess ourselves. And this is why I think part 2 of the MOC makes a ton of sense, where you have most of them are requiring self-assessment and objective measures so that we can start to say, what am I really good at and not good at? And then I can spend more time working on the domains that I'm actually less good at. So in wrap up, as I hit the future topics, I think these are important issues. I think if we drove CME, I would suggest a lot of GME in terms of the classroom side of what we do would be the same as well. I think it's a little harder on the UME side. They're not sure what's relevant yet. They're not sure what the experiences are yet. So I think they're a little bit closer to the opposite end of this, but it's still a spectrum. So I would say that again, that adult education principles are important. I think we need to think more about them, and I think we need to incorporate them more. I envision a day where a lot of the CME activities that we would do, you would take a pretest that was not just 5 questions that you could answer and gave you some answer back and then you entered into the education, but that the education would be driven. So in other words, it would be an objective assessment that would then lead you to data in domains you're weaker in, as opposed to you wasting time on things you actually scored real well in. I think lifelong learning does work, and even though it's been poorly designed and poorly monitored, I think that I can't produce data for you in terms of analyzed science right now. I can tell you that when the meta-analysis or the systematic review gets redone, that the majority of the publications, and there may be publication bias, but the majority of publications in the adult ed CME end of physician world now are all performance improvement oriented projects, are all being associated with some significant improvement in behavior, performance, patient outcome. So I think you'll see the data skew more as people get more and more focused at that issue. And I think we might be like fine wine, and we might get better in some ways as we get older, but wine that's not stored well and isn't managed well and handled well also has its problems. So I think we do have to do work, and so I'm glad to know that if we have to do work, that there is a field that can help us do that. I've hinted we need a conceptual model, we need a taxonomy. There's a group through the Society of Academic CME that's working on a multi-year project on this particular piece. We need to really get better at understanding some of the randomization and control issues in adult ed in healthcare, and better accepting of qualitative data, which has been really, I think, difficult in many environments. We clearly need to use tools that have been validated, and if we're designing new tools, then go through the steps of validating those tools. And I think if we do that, then we're going to be much better at figuring out what is the value proposition that we're actually talking about here. What should we be attending? What should we spend money on? How do we do that? What do we really want to get out of it so that we could actually see a difference? You're seeing in many environments that feedback and audit model or a coaching model are becoming very common. There's several CME offices here in New York that have almost completely gone over to the coaching model. If they deal with large family practice audiences, they're doing meet with 6 and 7 and have a facilitator in the room, and a lot of the CME is going into much more of that model. What can you learn in practice, relevant, bring a couple of charts, let's discuss. In fact, at the classic CME environment, what I would tell you is we see the following, and I think you'll shake your head yes, is that the typical talk on high blood pressure is really an epidemiology, etiology, population-based talk. For the next 1,000 people with high blood pressure, here's what you're supposed to think about, here's what you have to do, etc. The questions at the end are the art of medicine. So Todd, what do I do when a person has hypertension, but they're 82 and they've had a previous stroke, they got renal disease, they have Guillain-Barré, and it's a solar eclipse on a Wednesday? Those are the questions that are being asked, okay? And so I think classic CME has served, if it allows time for adequate Q&A and discussion. It does get both the science and the art out there. So I think there's much work to be done. If you're not helping us in this field of education, research, and science, then I hope you will join us in the endeavor, and I hope that was useful for you. And you didn't raise a red placard at me, so